Well, obviously, I think I have my work cut out for me. It's a tough one, and honestly, I didn't make a case that was easy to contort in any way. I would have to say that for a patient with brain metastases, PS2, it's hard to even argue the point that you should use anything but an EGFR TKI up front. The main point I would make is that I agree with a great deal of Jeff's comments, except that I think that, first of all, almost none of that applies specifically to first-line therapy. And secondly, that there's a lot of speculation in there about whether we really are doing better. I think that it's certainly open to debate whether we're doing substantially better with acquired resistance now than a few years ago. We certainly don't have compelling data to say that. And I'm actually quite dubious that dacomitinib or afatinib provide any meaningful benefit in acquired resistance right now. And I'm also not entirely sure that these treatments offer anything more than greater toxicity and equivalent efficacy. I don't think that a difference of 13.6 versus 13.1 months of median survival amounts to anything. And I'd also just say that for patients with acquired resistance, we do have a trial of afatinib followed or versus placebo that showed a numerically worse survival for afatinib versus placebo. So I would not take those points as a truism. Certainly, the IPASS trial, to me, was a landmark study and transformative in our understanding that mutations are far more important than clinical factors. Before this, I was one of many people who was largely a clinical selector. This was a clinically selected trial, enriched for light or never smoking Asian patients with an adenocarcinoma, the prototype of what you meant to telegraphically say this person is highly likely to benefit from an EGFR TKI, but only 60% of those patients actually had it, and in those patients you had a remarkably better progression-free survival and response rate in the recipients of gefitinib. But as Jeff mentioned, there was no difference in overall survival despite the may possibly. We don't have that yet. I'd also point out that on the right side of the slide that the patients with an EGFR mutation in this study, even when they got chemotherapy, had a response rate that was nearly 50%, so certainly striking. What we saw after that were several other prospective trials, all variants on the theme of chemo, standard doublet chemo versus an EGFR TKI, all showing significant favoring of response rate and progression-free survival for the this was in a selected population by EGFR mutation, all showing that in short term you did get a substantial benefit, but in the long term, no difference in overall survival in the studies that have looked at it. This is another West Japan lung cancer group showing no difference. Now, admittedly, there is the point of crossover, but that's the way it is. These are drugs that are commercially available, and what I would basically say is that it does not matter whether you go 2 blocks north and 1 block west, or 1 block west and then 2 blocks north. You end up at the same corner at the same time. And so I think that to portray it as a crime against humanity, that you must take 2 blocks north before turning west is a misleading point. Here's another study. This is just the update showing no difference and, if anything, slightly superior survival. So no detriment, no evidence of any detriment in the patients who started out with chemotherapy. You can go on, and if anybody is and should be getting an EGFR TKI afterwards, it's the patients with an EGFR mutation. That's not a question that they should be getting it. The question is whether it is absolutely critical. It must be given first line, and the evidence just does not show that. Here's another study, Optimal with Erlotinib. When you look at overall survival, those curves are just neck and neck, no difference between them. URTAC trial same result, and yes, these patients, 95% or so crossover, and this is at the time of progression. What I'm going to make the key point of is that the real benefit of maintenance therapy that we've seen is that you essentially guarantee that all of the patients who you intend to get a treatment actually get it. We don't actually have data that maintenance therapy given after 4 cycles is clearly better than giving that exact same treatment to the same number of patients after a 6-week break or at the time of progression. All of the studies that have been positive for maintenance therapy show that, that the survival benefit is seen in the setting of more patients getting that treatment early and fewer patients actually receiving that same treatment later. The benefit, if you do cross over to an EGFR TKI, is that you essentially guarantee that everyone is going to get the therapy you intend them to get. So in prospective trials, you can see that you have essential equivalence of the chemotherapy arm in the studies that have reported it. This is, at this point now, becoming a difficult slide to keep updated because there are several other studies that are all consistently showing the same results. In the short term, you get a better benefit with the EGFR TKIs, and all of the points that Jeff mentioned are completely true. The real issue is just you can get those benefits now or you can get those benefits in a few months, and it's the same exact benefits in terms of quality of life and symptom management, et cetera. I'll mention that in the SATURN trial, which was with maintenance Erlotinib, there was a striking difference, a hazard ratio of 0.1 favoring progression-free survival, favoring Erlotinib recipients. That we don't see hazard ratios of 0.1 in lung cancer, and yet the curve you don't almost ever see after that is overall survival, which was completely negated when everyone just ends up getting the same treatment later. So we should really keep in mind that the issue is just access to the drug and not really the timing. Finally, I'll just mention that in the optimal trial, in the patients who tended to do best were those who absolutely received both the chemotherapy and the EGFR TKI, and that's better than either alone, including TKI only, which is the middle curve there. So conclusions in the first-line setting, EGFR TKI is associated with superior PFS and response rate consistently, but there's no evidence of any improvement in overall survival. And there is some evidence that patients who do best are those who definitely get both. Now, patients appear to have the same probability of benefit from the TKIs, whether they get it first line or after that. And the question is whether it's clear that there's the same benefit from chemotherapy in the second-line setting as in the first line. This is a table that I got from who? Oh, yeah, Jeff, that highlighted that the response rate in the few studies that have looked at this are in the teens. Now, it's not definitive, but this is a far cry from the 47% response rate that was seen in the IPASS trial or the 30% response rates that were seen in several other trials of first-line chemotherapy. And again, the evidence we have suggests that the patients who have an EGFR mutation tend to do better with chemotherapy than patients who are EGFR wild type. These are not results that suggest that that is the case when the chemotherapy is given afterwards. So the evidence we have is that the EGFR TKIs are every bit as effective given after chemotherapy, but chemotherapy very well might not be as effective if given later on in the disease course. So the advantages of maintenance Erlotinib are that the benefit of an EGFR TKI for these mutation-positive patients is the same regardless of timing. The key is that it's absolutely critical that these patients get it, and that the chemotherapy benefit may be less, and perhaps significantly so, if it's given later rather than sooner. The maintenance approach is the guaranteed way to actually deliver that therapy to patients while giving them chemotherapy at a time when the best evidence we have demonstrates that it's maximally effective. So thanks very much.
Thanks, Jack.